Hello, and welcome to the introductory training on documenting functional abilities for activities of daily living and patient care for the upcoming changes on October 1st, 2023. This training is intended for nurses and nursing assistants with the basic knowledge of documenting ADL care. My name is Cindy Cates, and I am excited to be the creator of this training. I have over 2 decades of experience in post-acute care. I've journeyed from being a nursing assistant in a small nursing home to becoming a registered nurse with experience as an MDS coordinator, director of nursing services, and regional MDS consultant. On October 1st, 2023, this documentation will play a critical role in our patient care processes for all patients and all payer types. So let's get on this vital journey together and aim to elevate the standard of care that we provide through meticulous documentation practices. I do not have any relevant financial relationships to disclose, and I will not be promoting any products. This training was developed with the final MDS 3.0 RAI Manual version 1.1811, effective October 1st, 2023. Handouts for this education session are available in the description of the video. For each knowledge check, I will encourage you to pause the video and use the knowledge check handout to gauge your level of understanding. So documenting ADLs, we're discussing a really important update to our work. We all know how vital it is to document ADLs or activities of daily living for the care we provide to our patients. There's a lot of big news for this coming October. The Centers for Medicare and Medicaid Services have made some updates on how we document those ADLs on all patients. They've decided that all healthcare settings should document ADLs in the same way. This means whether you're in a hospital, a nursing home, or providing home health care, will all be using the same language and the same format to document ADLs for our patients. So why does this matter? Why is this a good thing? It makes it much easier for each healthcare setting to communicate to each other on what the patient needs are. So mark your calendars. This way of documenting will start on October 1st, 2023 for all patients. To everyone, this represents our current approach to documenting each ADL. And as you all know, we answer 2 key questions for every ADL we document. Number 1, what was the patient's self-performance? Were they independent, supervision, limited, extensive, or dependent? And what level of support did the staff provide? Did we do setup assistance, 1 person, or 2 people? New way we'll be documenting ADLs. Instead of answering 2 separate questions about self-performance and the level of support we provided, we will use a 6-point scale. This scale will cover both of those questions, and the new term we'll be using is functional ability. This single scale gives us a streamlined way to understand and describe how a patient is doing and how much help they are getting from us. Wondering, how is this new 6-point functional ability scale different from the old way we used to document? Well, the new scale takes some of the categories from the old system and combines them together, and others, it breaks them down into more specific groups. Let's take a closer look to understand how each category from the old system translates into the new one. First, let's focus on self-performance. Independent, it'll still be coded as independent. Supervision and limited are now bundled together, and it is coded as supervision or touching. Extensive is getting a bit more detailed. It's now split into 2 groups, partial moderate and substantial maximal. Dependent that stays the same. It is still coded as dependent. Turn our attention to how support provided fits into the new 6-point functional ability scale. Support provided was the second question we would be asked on the old system on each ADL. So if we coded setup support on somebody, this is now setup or cleanup. One-person support can be coded in multiple ways and really depends on what the patient's needs are. So if you are using one person, this could be supervision or touching, partial or moderate, substantial, maximal, or even dependent. But if you're using two people to help somebody, that is always now coded as dependent. Deeper into what each of these terms in our new 6-point functional ability scale actually means. First off, what do we mean by helper? A helper is someone who works directly for our facility. This includes our own staff and people we contract, like nursing agency staff or rehabilitation teams. This doesn't include people like hospice or nursing students that aren't contracted by our facility, and it also doesn't include family members. Now, onto the scale. Independent, this means the patient can do the activity all by themselves. No help needed. Setup or cleanup. The helper sets up or cleans up. The resident completes the activity. The helper only assists prior to the activity, but not during the activity. For example, the helper might cut up food or set up hygiene items, but they don't need to help during the activity itself. Supervision or touching. This means the helper provides verbal cues, touching, studying, or contact guard assistance as the resident completes the activity. This could be constant support or just now and then. For instance, a patient might only need verbal reminders to finish the activity safely. Partial moderate. A helper does less than half of the effort. This effort includes lifting, holding, or supporting the trunk or the limbs, but they provide less than half of the effort. Substantial maximal. The helper does more than half of the effort. So this means that the effort is the helper lifting or holding the trunk or the limbs, and they provide more than half of the effort. Dependent. This means the helper does all of the effort, and the resident does none of the effort to complete the activity. This also has a second part of the definition. It can also mean that the assistance of two or more helpers is required for the resident to complete the activity. Even if the second helper is just supervising or following close with equipment, the ADL is still coded as dependent when two staff members are assisting. This category also includes situations where one helper is supporting the patient and another is managing equipment like a lift. CMS, or the Centers for Medicare and Medicaid Services, made a decision tree to help us code the functional ability of each ADL. To use this, you start at the top and you work your way down the tree to find what code is applicable to your patient. So we would start with the top definition. If that applies, we would go to yes and see what code is on the right. If it doesn't apply, we would go towards the bottom with no and read the next definition until we find one that applies to our patient. This handout will be available with a link in the video description. In certain cases, there might be instances when a specific ADL isn't completed or attempted for a patient under your care. In the past, this situation was documented as activity did not occur, and depending on your electronic healthcare system, you may have had other options such as not applicable or resident refused. With the new ADL coding, there's now a structured way to account for these instances where an ADL hasn't occurred. It's important to note the available options may differ based on your facility's documentation practices. So if you do not have these options, ask your supervisor for guidance on what to code. if an activity does not occur. The options are resident refused, not applicable, not attempted due to environmental limitations, and not attempted due to medical or safety concerns. Why we use each of the codes for when an activity didn't happen. Resident refused. This means the person said they don't want to do the activity or ADL. An example is if someone doesn't want to take a shower. Not applicable. This is when an activity wasn't done because the person couldn't do it even before they got sick or hurt. For example, if someone can't walk because they lost their leg, and this was true before they had a new medical problem that made them need help, we would code not applicable. Not attempted due to environmental limitations. This code says the activity didn't happen because something around us stopped it, like not having the right space, equipment, or even the weather conditions. Imagine someone couldn't practice stepping up on a curb outside with the restorative aid because it was raining. Not attempted due to medical or safety concerns. This code is used when a person or staff can't do the activity because it's not safe. For example, if someone can't walk because their leg is broken and the doctor says they shouldn't walk on it yet so it can heal. By using these codes, we explain why an activity didn't happen better. It's like telling a clear story for each situation. The functional ability 6-point scale isn't the only thing that's changed. We have a lot of updates to ADLs, but don't worry, it's easier than it looks. ADLs have been divided into smaller, more specific parts. And remember, you're no longer answering 2 questions for every ADL. Now we only use a 6-point scale to code and document each ADL. Now we'll go over what each new ADL category means so you're well prepared. Your organization may not have every item set up for routine charting, and some of these options may not be available for you to document on at all. Ask your supervisor what charting you are responsible for each shift. Eating. The definition of eating is the ability to use suitable utensils to bring the food and or liquid to the mouth and swallow food and or liquid once the meal is placed before the resident. What it also includes is when a patient eats finger foods with their hands. Liquid diets. We can code the resident's ability to drink the liquids. What it does not include is nutrition given by other means, such as through G-tubes. If a resident needs nutrition through a G-tube and also drinks, we only code how the resident eats food by mouth. So if they're G-tube only and they do not eat, we're going to code this as not attempted. Here is the eating knowledge check. I encourage you to pause the video and complete the handout. Once the staff brings Ms. Smith her food, she can open all containers and cut up her meat. How should we code Mrs. Smith's eating? Mrs. Smith would be coded independent. She can do everything herself, including the setup assistance of her tray. Mr. Link has a lot of shaking in his hands and is unable to feed himself any part of the meal. Staff perform all of the effort. How should this be coded? This would be coded as dependent. Mrs. Green has to have several reminders to slow down and chew her food carefully through the meal so she does not choke. How should we code this item? This would be coded as supervision or touching because staff is giving her cues to swallow safely. Miss K has a G-tube and does not eat any food by mouth. How should this be coded? This would be coded as not applicable And you would also want to talk to your MDS nurse or supervisor to see which code would be the most appropriate, if it is a not attempted code or a not applicable code, or what is available in your software to code items that do not apply to your patient. Mrs. B is able to drink her orange juice, but staff has to feed her all of her food. Staff completes more than half of the effort. How would we code this item? This would be coded as substantial or max because staff is completing more than half of the effort for her. Mr. Bluford gets tired during the meal and needs some help towards the end. Staff feed about 10 minutes of the 40-minute eating activity, so staff are completing less than half of the effort. How would we code this? This is coded as partial moderate because staff is completing less than half of the effort for the meal. Mr. Brigg needs more help than tray delivery. He is not able to get the lid off his coffee to put the cream and sugar in, but he can eat and drink without help. How do we code this? We are coding this as setup or cleanup because Mr. Brigg needs help with the setup of his meal tray. Now let's take a look at the hygiene items that we will be coding. These items include oral hygiene, toileting hygiene, and personal hygiene. Oral hygiene is the ability to use suitable items to clean teeth. If a resident has dentures, this refers to their ability to insert and remove their dentures and manage soaking and rinsing them. If a resident doesn't have teeth, this refers to their ability to clean their gums effectively. Toileting hygiene. This is the ability to maintain perineal hygiene and adjust clothes before and after voiding or having a bowel movement. When an ostomy is involved, like a colostomy bag or a urostomy, this includes the wiping of the opening, but not managing the equipment and doing tasks like putting it on or emptying it. Catheters. This involves perineal hygiene, but it does not include inserting the catheter or emptying of the catheter. Personal hygiene. This is the ability to maintain personal cleanliness. It includes tasks like combing the hair, shaving, applying makeup, washing and drying your face and hands. This category excludes bathing, showering, and oral care. Now let's do the hygiene knowledge check to check and see what we learned with hygiene. I encourage you to pause the video and complete the hygiene section of the knowledge check handout, and then press play when you're finished, and then we'll go over the answers together. Oral hygiene. Mr. Hamilton has dentures. He can brush his gum and cleans both of his dentures the best he can. But because he only has the use of one hand, it's tough for him to get them thoroughly cleaned. The staff help him finish cleaning the dentures. He places them back in his mouth, and staff do less than half of the effort. How would this be coded? This would be coded as partial moderate. Staff provide less than half of the effort. Toileting hygiene. When Mr. Jones used the toilet, the certified nursing assistants provided steadying assistance while he pulled down his pants and underwear. When he finished, the CNA provided steadying assistance as he wiped his perineal area and pulled up his pants and underwear without assistance. How would this be coded? This would be coded as supervision or touching. The CNA provided steadying or touching assistance when he was completing the toileting hygiene item and also while he was managing his clothes when he pulled down his pants and underwear. Personal hygiene. Miss Maple is not able to complete any part of her hygiene. In the morning, staff wash and dry her face and comb her hair before breakfast. How would this be coded? This would be coded as dependent. Staff does all of the effort. Our next item is shower bathing self. This means the ability to bathe self, including washing, rinsing, and drying. It includes the face, upper and lower body, perineal area, and the feet. This is any location. It can be in the shower, in the bathtub, at the sink, in the bed. What it excludes is washing the back and washing the hair. And it also excludes transferring in and out of the tub. This is only the bathing item itself. Now let's do the knowledge check on the shower and bathing item. I encourage you to pause the video, do the knowledge check for shower and bathing on the knowledge check handout, and then push play on the video. Mr. Alex faces mobility challenges due to several medical issues. He prefers to wash his body while sitting near the sink in his bathroom. A certified nursing assistant steps in and helps him wash, rinse, and dry his upper arms, hands, upper legs, lower legs, buttocks, and back. How would we code this item? This will be coded as substantial maximal assistance. The CNA completed more than half of the effort. Remember, we can document bathing at the sink, and bathing and washing, rinsing, drying the person's back is not included. So the items that we are looking at are the arms, hands, upper legs, lower legs, and buttocks in this instance. Now let's take a look at the ADL item dressing. It is now not just one dressing item. It is divided into 3 smaller subcategories. These subcategories include upper body dressing, lower body dressing, and putting on or taking off footwear. Upper body dressing is the ability to dress and undress above the waist, and this includes fasteners, like buttons, snaps, or zippers if applicable. It also includes some non-typical clothing items, such as orthotics, binders, back braces, prosthetic hands and arms, and of course any upper body clothing, like undergarments, shirts, sweaters, sweatshirts, and button-downs, and even pajama tops. What it excludes is hospital gowns. So if you're just putting a hospital gown on somebody, it does not get included in upper body dressing. Lower body dressing is the ability to dress and undress below the waist, and it includes fasteners here, like buttons, snaps, and zippers. It also includes some non-typical clothing items, like knee braces, elastic bandages, shrink socks, lower limb prosthetics, orthotics, undergarments, incontinence briefs, pants, shorts, skirts, etc. The one thing that it excludes here is footwear. Where you do include footwear is putting on or taking off footwear. This is the ability to put on and take off socks and shoes or other footwear that is appropriate for safe mobility. And this includes any fasteners on the shoes or socks like Velcro or shoelaces. This area includes socks, shoes, boots, running shoes, ankle-foot orthosis, elastic bandages, foot orthotics, orthopedic walking boots, and compression socks or compression stockings. Some areas that we also need to think about with dressing is when we are determining the appropriate code, we have to assess each specific area and code each different activity. So we only code that specific aspect of dressing in that distinct area. So if we're just talking about a shirt, that shirt doesn't count in lower body dressing and it's not going to count in footwear. We're only going to code the resident's ability to put on that shirt in upper body. So we have to give a distinct picture of each one. This ensures that we are accurately representing the patient's functional capabilities with each one of the dressing activities. Now let's do the dressing knowledge check. I encourage you to pause the video and complete the dressing knowledge check on the knowledge check handout. Upper body dressing. Mrs. E decided to stay in bed and only wanted to put on a new hospital gown to stay comfortable. Staff brought her a new gown and she was able to remove the old gown and put a new one on. How would you code upper body dressing? Upper body dressing would be coded as resident refused. She didn't wish to get dressed, and a hospital gown is not included in upper body dressing. Lower body dressing. Which of the following items are considered when coding lower body dressing? A, pants, B, a knee brace, C, prosthetic leg, or D, all of the above? This is D, all of the above. Lower body dressing can include knee braces, elastic bandages, shrink socks, lower limb prosthetics, orthotics, undergarments, incontinence briefs, pants, shorts, skirts, etc. Putting on or taking off footwear. Mr. Zook prefers to wear only non-skid socks. Staff lay his clothes out, including the socks on his bed each morning. He is able to put the socks on without assistance. CNA Peggy codes putting on or taking off footwear as setup assistance, but Rachel thinks this is wrong because he doesn't wear shoes. Who is right? Peggy coded correctly. Putting on and taking off footwear does include socks. Bed mobility, just like dressing, has been divided up into smaller subcategories. Bed mobility now includes roll left to right, sit to lying, and lying to sitting. Roll left to right is the ability to roll from lying on the back to the left and the right side and to return to lying on the back on the bed. Sit to lying is the ability to move from sitting on the side of the bed to lying flat on the bed. And lying to sitting is the ability to move from lying on the back to sitting on the side of the bed. And they have to be able to sit there with no back support. All bed mobility activities consider all kinds of sleeping surfaces and not just beds. We have to consider alternative sleep surfaces like recliners, chairs, and couches. Some patients may not be able to perform some of the bed mobility activities, such as some patients may not be able to go from sit to lying or lying to sitting. So remember to use the appropriate not attempted or not applicable code. Now let's do the bed mobility knowledge check. I encourage you to push pause and complete the knowledge check handout for bed mobility. And this knowledge check will be matching the type of bed mobility to the definition. Roll left and right. What is the definition of roll left to right? This is B, the ability to roll from lying on the back to left and right side and return to lying on the back on the bed. Sitting to lying. What is the definition for sitting to lying? This is C, the ability to move from sitting on the side of the bed to lying flat on the bed. Lying to sitting. What is the definition for lying to sitting? This is A, the ability to move from lying on the back to sitting on the side of the bed with no back support. Transfers are another item that is now divided up into multiple areas. We can code a lot of different types of transfers. The first area is part of a transfer, and that is sit to stand. The next is chair to bed to chair transfers, toilet transfers, tub and shower transfers, and car transfers. Sit to stand is the ability to come to a standing position from sitting in a chair, wheelchair, or on the side of the bed. So this is only part of a transfer activity. So when we think about a person doing this with a sit to stand lift, if one person assist is used, we would code substantial maximal. If two-person assist is used, we would code dependent. If we're using a full body lift, sit to stand cannot occur. So we would code not applicable or did not occur. Chair to bed or bed to chair transfers are the ability to transfer to and from a bed to a chair or wheelchair. If a stand-up lift is used, if we're using one person, again, we're going to code substantial maximal. If two-person assist is used, we're going to code dependent. Toilet transfers. This is the ability to get on and off of a toilet or commode. This excludes clothing management, transferring on and off of a bedpan. Tub transfers are the ability to get in and out of a tub or shower. And car transfers are the ability to transfer in and out of a car or a van on the passenger side. This excludes the ability to open and close the car door or fasten the seatbelt. So let's complete the transfer knowledge check. The transfer knowledge check, you are going to read through the scenario and identify each part of the scenario is which part of a transfer. I encourage you to pause the video and complete the knowledge check handout and then unpause the video so we can go through it together. Miss Lawrence is ready to get out of bed for the morning and is sitting and waiting on the side of the bed to get help into her wheelchair. One staff member places a gait belt around her waist and assists in lifting her up to a standing position, with staff completing less than half the support. Once standing, she only needs contact guard assistance to stay steady and pivot to the wheelchair. She wheels herself to the bathroom and uses the grab bar to stand, and the staff member has to cue her to lower herself slowly onto the toilet by using the grab bar. After she's done in the bathroom, the staff start to assist her to take a bath before her doctor's appointment. She likes to use the Whirlpool tub. When she moves from her wheelchair to the tub and back, one staff member helps her stand and complete a pivot transfer by using a gait belt. She needs trunk support to get in and out of the tub, and staff provide less than half of the effort to help her. Her daughter picked her up for her appointment, and staff assisted to get her into the passenger side of the car. They used a gait belt with a stand and pivot transfer with one staff member and the other staff member to move the wheelchair out of the way to increase safety. So for our sit to stand transfer, it's located here, where one staff member is placing the gait around her and assisting her to go from a sitting position on the side of the bed to a standing position. Our chair to bed transfer is the next sentence. After we get her standing, she needs contact guard assistance to stand and pivot to the wheelchair. A toilet transfer is next. The tub transfer is here. And the last is the car transfer. And that is dependent because we used two staff members. The next ADL item we're going to go over is walking. So before with walking, we would code walk in the room or walk in corridor. Walking is a little bit different now. We have smaller subcategories. The first one is walk 10 feet. The next is walk 50 feet with 2 turns. After that is walk 150 feet. And the next is walk 10 feet on uneven surfaces. Walk 10 feet is, once standing, the ability to walk at least 10 feet in a room, corridor, or similar space. Walk 50 feet is with 2 turns. The resident must be able to make 2 90-degree turns with walking 50 feet and 2 turns. Walk 150 feet is, once standing, the ability to walk at least 150 feet in a corridor or similar space. It's important to note that walk 150 feet does not require the resident to be able to make 2 turns, although it can still be coded if the patient does make turns while walking this distance. If a facility's layout doesn't allow the resident to walk 150 feet without making turns, and the resident can't safely manage 150 feet, then you should code not attempted due to environmental limitations. Walk 10 feet on uneven surfaces. This is walking 10 feet on an uneven or sloping surface. This can be done indoor or outdoor, and it can be done in areas such as turf or gravel. It's important to note when coding the 6-point scale, the resident must complete the entire walking task without sitting down. If the resident cannot walk the specified distance for each one of the codes, it should be marked as not attempted or NA. Now let's complete the walking knowledge check. I encourage you to pause your computer and complete the knowledge check handout, unpause the video, and come back and listen for the answers. Walk 10 feet. Miss Red walks to the bathroom in her room, which is 10 feet away. Staff stand close to make sure she remains steady. This would be supervision or touching assistance because the patient walked 10 feet and the staff supervised to ensure her safety. Walk 50 feet with 2 turns. Mr. Elm walks to the dining room for lunch without staff assistance. He makes a 90-degree turn to the left out of his room and a 90-degree turn to the right to go down the hallway to the dining room. The total distance is 50 feet. How would we code this item? This would be coded as independent. The patient is able to walk without staff assistance or supervision, and he walks 50 feet in 2 turns. Walk 150 feet. The dining room is about 180 feet from Mr. Walker's room with no turns. He walks with a walker without help from staff. He gets almost halfway there and has to sit down for a break. Then he walks the rest of the way without stopping. How do you code this walking activity? This is coded as not attempted. The resident can take a short standing break, but if the resident needs a sitting break, the activity is coded as not attempted. Walk 10 feet on uneven surfaces. The restorative aide walks about 12 feet with Mr. Harper across the landscaping gravel to water the plants. He requires the restorative aide to steady him with a gait belt. How do we code this item? This is coded as supervision or touching. The gravel is an uneven surface, and the patient requires staff to help steady them, which is touching assistance. The next item is wheeling a wheelchair. Wheeling a wheelchair wasn't specifically available on our old ADL coding, and this was kind of included on locomotion on the unit. But now wheeling a wheelchair is its own separate item. We have 2 separate areas that are the ADLs. The first is wheel 50 feet with 2 turns. The next is wheel 150 feet. Wheel 50 feet with 2 turns. This is once seated in a wheelchair or scooter, the ability to wheel at least 50 feet and make 2 turns. Wheel 150 feet is once seated in the wheelchair or scooter, the ability to wheel at least 150 feet in a corridor or similar space. This includes motorized wheelchairs and scooters. If the resident normally sits in a wheelchair when moving about. It excludes when we use a wheelchair for transport only, and this is such as when we're only using it to get to and from therapy because it's a really long distance, or maybe we're using it to quickly be able to take the resident to the weight room to get their weight. If they're normally not using a wheelchair, we should not code wheeling wheelchair. Now let's complete the wheelchair knowledge check. I encourage you to pause the video, complete the wheelchair knowledge check on the knowledge check handout, and unpause the video to see what the answers are. Wheel 50 feet with 2 turns. Mr. Owen is paralyzed from the neck down. He has a motorized wheelchair that he propels with his chin. Once he is in the wheelchair, he is able to propel himself 50 feet with 2 turns without staff assistance or cueing. How do we code this item? This is coded as independent. Once in the chair, the patient does not need staff assistance, and the motorized wheelchairs are included in this ADL item. Wheel 150 feet. Miss Minnie, once in the wheelchair, can wheel herself about 20 feet to the dining room. Staff wheel her the rest of the way. How should this be coded? This is coded as substantial maximal. Staff is completing more than half of the effort in this ADL activity. Stairs is the next item that we will be talking about. Stairs was not previously available in our previous ADL documentation. When you look at stairs, we have 1 step or a curb, 4 steps, or 12 steps. 1 step or curb is the ability to go up and down a curb and or down 1 step. 4 steps is the ability to go up and down 4 steps with or without a rail. 12 steps is the ability to go up and down 12 steps with or without a rail. If the facility environment does not have 12 steps, we can still code these by using a combination of 4 stairs by going up and down the 4 stairs 3 times consecutively in a safe manner. This is an acceptable alternative to comply with the intention and meet the requirements of the activity. When we're looking at each one of these step items, all of them include the ability to go with or without an assistive device. If the level of assistance changes going up and down the stairs, for one item in particular, we would code the more dependent level. Many times, the nursing staff is not completing this item with patients, so this may not be an available option to you in your ADL software. Be sure to ask your supervisor how your ADL software works. Let's complete the stairs knowledge check. I encourage you to pause the video, complete the knowledge check on the knowledge check handout, and then unpause the video to see what the answers are. The restorative aide walks Mr. Smith outside each day. They practice stepping up and down off the curb for balance. He requires contact guard assistance for safety. How do we code 1 step curb? This is coded as supervision or touching. The patient required contact guard assistance, which is coded under supervision or touching to complete the ADL. The outdoor gazebo has 4 steps, and Mrs. Glass is planning to go home and uses these steps to help her practice stairs because she will need to be able to get up the stairs in her home. The physical therapist assists her with a gait belt with contact guard assistance beside her, and a certified nursing assistant stands behind her for safety. How do we code this item? This is coded as dependent because 2 staff members assisted during this ADL. Miss Bear has transitioned to restorative nursing while waiting on his handicap apartment to become available. One of his programs includes walking up and down the stairs in the therapy gym. The restorative aide stands close by to ensure he is using the cane correctly and safety. There are only 4 stairs, so he goes up and down the stairs 3 times consecutively, only needing 1 cue when he started. How do we code 12 stairs? This is coded as supervision or cueing. The patient required cueing and supervision for the ADL, and although the facility doesn't have 12 steps, he completed the 12 steps by consecutively going up and down the stairs. Picking up an object is also a new ADL item. Picking up an object means the ability to bend or stoop from a standing position to pick up a small object, such as a spoon from the floor. This includes using a reacher or a cane or walker for balance. So remember, this is from a standing position. A patient can't be sitting down to pick up an object. Now let's knowledge check ourselves on picking up an object. I encourage you to pause the video and use the knowledge check handout. This one is true or false. If a patient is sitting in a wheelchair and picks up a small object off the floor, you should code this item. This is false. This ADL is only coded for patients picking up an object from a standing position. When coding this item, it includes using a reacher to pick up a small object from the floor while standing. That's true. Picking up an object can be coded if the patient picks up an object with a reacher from a standing position. If a resident has to use a walker to keep their balance when picking up a small object from the floor, you should code that the activity was not attempted. This is false. This item includes using a walker or a cane for balance when picking up a small item from the floor. This concludes the ADL training. Keep in mind your documentation for not applicable or not attempted coding may vary based on your facility's policies and standards. If you have any questions about how to accurately document ADLs, don't hesitate to reach out to your supervisor in your building for guidance.